I want the video ones.
Evening, everybody. Nice to see all your smiley faces after a busy day at work. Just a couple of minutes to go, so we'll just sort of wait for a few more people to join us. And brilliant, thanks everybody for joining that's come tonight. Hopefully you're going to get a nice bit of learning out of it. I'm hoping you've all come for a session on tests and a tiny bit on treatments in women's health, and we're doing it in primary care, so primary care setting here. We've got about an hour and a half, but we'll do an hour and a bit and then questions at the end. And just whilst we're waiting for the last few people to join us, I'll just pull up the screen. And just put the intro slide up. And hopefully you guys, Gail, can you see that? Give me a thumbs up. Can you see that all right? Brilliant. Great. Good. That's brilliant. So hopefully this is what you've all come for rather than something else. Now, we're on Zoom, and I like Zoom because it seems to be pretty simple and easy, and anything that's simple and easy helps. So first of all, have a little look at your Zoom app, and there is under the More section, 3 dots, you'll find a little bit that says chat. So if you've got any questions for me, just click on the old chat button and just put them in there. You can do them straight to me, or you can do them to everybody, it doesn't matter. So use that for putting any questions in there, and I'll come to them at the end and we'll go all the way through them and we'll see how many questions we can get answered. And then I just thought, whilst we're waiting for the last few people to join, just make sure, just put a few rules up there. Just switch off your cameras and your phone and your mute yourself, just keeps the background noise down. But use the chat for pushing any questions in there whatsoever, just ask in the chat. And I'm going to go through as many of those questions as I can, but I'm not going to send these slides out. So just listen, just soak it all up. If you want to take a picture of a screen of something that's of use to you, that's absolutely fine. If you want to take notes, I'm hoping that if you learn just one thing that will change your practice from tonight, that's a really good learning opportunity for you guys. So don't spend hours writing notes, just have a good old listen. Right then, I think we will get started because, yeah, it's just after 6 now. So welcome everybody. For those of you that don't know who I am, I'm Julie Oliver. I work as a GP in Lancaster. I work a couple of days as a GP, and the rest of the time I do a mixed bag of teaching, and I run my own business called Durham Gynae, and I'm a clinical director of the Primary Care Women's Health Forum. And as well as that, I work for various different pharmaceutical companies doing different pieces of work for them. So you can see where my sources of income come. Tonight, nobody sponsored this meeting. I've done it for the love of education. And so it's there's no reps going to pop up and tell you about their products tonight. We're just going to go straight on and go through what products we've got, what things we're going to talk about. So this is tonight's aims. I'm doing an update on the latest advice guidance on testing and some treatments in women's health. And we're going to cover, I thought we'd just do a few things that maybe we've not done ever before, really bits on pregnancy testing. Those of you that heard me talk before know what I go on about swab testing, but I'm going to go over it again for you tonight. We'll do a bit on the smear screening programme and what's going on and what's changed. We'll do something on blood tests as well, what's going on with blood tests, what you maybe should and shouldn't do, and we'll do a little bit on imaging for those of you that are ordering images, and maybe nurse practitioners, or any GPs or doctors in the audience that might be ordering. It's what to do with that imaging and when to do certain things with it. So again, before I get started, everyone just have a look at your screens, make sure that your sound's muted and your cameras are switched off so that you can keep looking at the slides. So let's start off with pregnancy testing, because I'm sure all of you offer some sort of pregnancy tests in your practice, which can be really variable what we offer and when we offer them. And I thought we'd just go through a little bit of the physiology of what happens with pregnancy tests, or HCG, which is what we're monitoring in the pregnancy tests. And you can see on the chart, you've got the the gestation across the top there, across the bottom, and then you've got the blood levels going up. These aren't comparable, they're different measurements, but it's just to show you what happens to HCG in an early pregnancy. So if we start off at 0, i.e. you're not pregnant, and then by the number 4, you are pregnant, basically your beta HCG does a massive rise at the beginning, at the very early pregnancy. And you can see the numbers go from very, very low to by 8 weeks, a really, really high level, okay? And then that beta HCG just dip down until about 4 to 6 weeks after pregnancy. And conversely, your progesterone and your estrogen levels, they just creep up as you get on through your pregnancy. So knowing those sort of numbers there, I thought we'll have a look at this chart, which is taken out of a gynecology textbook, to say what actually are those numbers of HCG. So this is looking at a singleton pregnancy, number of weeks pregnant, so that's the number of weeks after the last menstrual period. So that would be week 3. A woman wouldn't have actually missed a period yet, but she would have had 7 days after conception. The beta HCG is very, very low. It still really hasn't done an awful lot. So that is when you could do a pregnancy test and you'd get a false negative result. So you've done one too early. But if you wait just 1 more week, which is then the week that your period would be due, basically you can see from week 4 onwards what the numbers on the beta HCG start to do. So week 4, there's a variable range, obviously, they creep up between 5 and 430. And then as you go week on week on week, you can see how high the numbers go. Then if you go to the very end of the pregnancy, you can see it takes between 4 and 6 weeks after a pregnancy for your beta HCG again to go right back down to less than 5 or 0. So now you know that, let's have a look at the different pregnancy tests that are on the market. And you'll all have different ones sent to your practice depending on which ones the labs have got a good deal on and which ones they're doing at the moment. But if you look at the left-hand side of that chart, you can see in the brackets how sensitive, i.e. when they turn positive. And most of those, I'm sure you've looked down that list already, will go positive at 25 international units per mil. And you were seeing there that really the numbers are in the hundreds of thousands when you hit mid-pregnancy. So if you look at those numbers, these tests are fantastically sensitive. They're very, very good at picking up pregnancy hormone. And over the years, those numbers have got lower and lower.
I thought you said there were no meetings today.
I just ask everyone to switch on to mute, please. So you're on mute. Thank you. So you can see your numbers. You can see that the numbers are quite low. And you can also see, if you, for instance, looked at the cyclo test one, that picks up a pregnancy at 10 international units. That's absolutely minuscule. So these tests that we're doing on urine samples are fantastically sensitive. So that's the first thing you should be aware of. Okay. And so that brings me on to the next question about doing beta HCG as a blood test in primary care. Is there really any role for it, knowing how good these urine pregnancy tests are? And I would say for most of us, we don't need to be doing this to confirm pregnancy. We might be asked by secondary care to be monitoring levels once they're monitoring, say, an ectopic pregnancy resolving or a molar pregnancy resolving when you're looking for numbers. But this is doing work for somebody else. This isn't the work that we should be doing ourselves. So for ourselves, for our own diagnosis of pregnancy, there really isn't any need to do blood tests. But we do them all the time. And I think you need to question, is it really necessary? And the reason it comes up as being really necessary is people often say, well, when I do a test, it's always negative. Well, these tests are fantastically sensitive is the first thing. So the first thing is, are they doing the test at the right time? There is no point doing a test really before you've missed a period. The second test is, are they actually able to read the test properly? And some people find it difficult to actually interpret the test. And then there's a cohort of people that say, no, it doesn't matter what I do, it doesn't come out positive. And that's really a strange anomaly. And if you look up the guidelines, what sort of things can make you have a false positive urine test, i.e. the test says you're positive, but you're not pregnant. And there's a few things like other sources of beta HCG, rare and wonderful tumours and things like that that can cause a falsely high level. And there are some women going through hormone tests, hormone treatments that can do that as well. And also there are the occasional drugs interactions that can cause false negative results. But on the whole, these tests are really very accurate. So you should be confident that the tests you're doing are accurate and good. You should also be absolutely sure you know what you're doing by reading the instructions at least once before you start doing the test. And I would also query whether you need to be doing these tests in-house for women to just confirm pregnancy. And I would say that those women can go away and be doing their own tests, and you would be doing the test to confirm some sort of abnormality in pregnancy. And that would be ectopic pregnancies or ruling out some sort of irregular bleeding pattern. So generally, to try and confirm pregnancy, I wouldn't be offering tests in the community for that. They should be going to the pharmacist to buy tests or getting a test done at the pharmacist. But you should be able to, and should be able to access tests if you're querying ectopic pregnancies and things like that. So question whether you need to do the blood tests or not. You might be doing them for secondary care, but for our own purposes, there's probably very little need to be doing blood tests for HCGs. So that's the first one. That takes me on quite nicely to pregnancy risk assessments. When should we be doing pregnancy tests? And when should we be, what should we be doing in order to assess a woman's risk of pregnancy? So the first piece of work for you guys to do is I want you to write down the 3 questions that you need to ask a woman to be able to assess whether she is at risk of pregnancy. You've got 10 seconds. Right. You are quite a small group, but I'm not going to pick on anyone tonight, you'd be pleased to know, okay? So 3 questions. First question, first day of your most recent period, when did that start? And be very clear in the words you use and allow your women to look on their apps, on their phone, in their diaries to try and give you an accurate date. So the very first day you started to bleed, most recently. And for that also you need to know, was that a normal bleed for you? Is that what you expected, when you expected, and how you expected? Second question, is contraception, are you using it? What are you using? How good are you using it? Have you had any mishaps, any late pills, any forgotten pills, any condom accidents? Is your coil in date? Is your implant in date? So that's all the contraceptive things you need to know. Are you using it and how good are you at using it? And then your third question you're asking is, when have you had sex? And you want to know that since your last period, when have you had sex? Okay. And with all that information, you can then work out what a risk of pregnancy is. Your job is to tease that information out and really drill down and ask the questions. So following that, once you've got that information, when do you need to perform a pregnancy test? Well, here's a few clues. 21 days or 3 weeks after the most recent episode of unprotected sex will give you an accurate diagnosis of pregnancy or not. Okay, if you do it earlier, you might get a false negative, but if you leave it for 21 days, you can be absolutely sure that that pregnancy test is accurate. So that's the first take-home piece of information. Ask those 3 questions and document them in the notes, okay? Your job is to find that information out. So let's go on, let's talk about swabs. And I thought before we talk about swabs, let's talk about what is normal, okay? And this is taken from a fertility document, but this shows you a normal menstrual cycle. So you can see across the top, you've got days of cycle, it's picked a 28-day cycle. And then you've got the next line across the top takes you through description of P in red means bleeding or period, and then you've got the following the rest of the cycle. D would mean for dry or no discharge at all, and then you've got the yellow section in the middle. And day 14 is highlighted because that would be ovulation day and that would be a fertile day. And you can see that a normal woman who is fertile, that has a regular menstrual cycle, will have a natural change in her discharge as her cycle changes. And some women use this as a way of working out whether they're fertile and whether they should or shouldn't have sex. It can be a form of natural cycle family planning. And other women do it to work out when they're fertile and they want to have sex, so they want to try and conceive. And you can see that there's a variety of different discharges women describe, which basically goes from a more thick, sort of sticky consistency to a more thin, clear, slippery or runny consistency. And that really is because that mucus also acts as a barrier, and a thick mucus will act as a barrier, and a thin, runny mucus actually helps and assists in fertility. So women who know the difference between their cycles can work out when they're fertile. But it's important as us to work out in primary care and understand that this is normal, okay? A woman will normally have a discharge. Now, the amount and quantity will change depending on where she's in her cycle, but it will change. So there are times where there's nothing, there's times where it'll be there. And actually, a lot of things that women are noticing are just changes. They're not abnormalities, they're changes in their normal discharge. So now you know what's normal. We also need to talk about what's going on a microscopic basis inside a vagina. And this is a norm in a premenopausal woman. You've got an acidic environment and you've got a whole selection of bugs that live inside the vagina naturally. Predominantly, you've got lactobacilli, which are those little dots, the little dark purple dots on that, and there's a big cell in the middle. But you've got a selection of candida, so thrush-like bugs in there, and Staph aureus, so that would be typical skin bugs, and group B strep, the one we've all heard of, it causes problems with babies being born and can cause sepsis in babies. But they all live there naturally anyway. And then you've got some anaerobes, and anaerobes are our friendly BV bugs that go when they overgrow cause the BV problem. And these coagulative negative staphs, a different kind of Staph aureus, and some other bits and bobs in there. So just like ears, noses and mouths, if you pop a swab inside a vagina, you will always grow a selection of normal bacteria or flora that are in there normally. Which takes me to the next question is, do you need to be putting a swab here? Okay, and this brings me on to swabs. So now you know that within your genital tract, you have a whole selection of naturally occurring bugs. And you also have a natural change in your menstrual cycle and your discharge within that cycle. First question to ask yourself is swabs. Okay, the dreaded triple swabs. Is there any role for doing swabs? So these are your charcoal swabs. They're a bit blurry. It's not your eyesight or computers. It's my slightly dodgy cut and pasting there. And these are just swabs that have got charcoal in the bottom or some sort of medium and a cotton wool bud. And you're just simply using the cotton wool bud to collect a sample of the discharge, pop it inside that medium. So that's charcoal or whatever it is, agar jelly, which will just keep the bugs alive. And then it's transported to the lab, plated out onto an agar jelly plate and grown in an incubator to see what sort of bugs grow in it. And you know, there's a whole list of bugs that will grow there normally. So this swab is useful for diagnosing a vaginal discharge if you don't know what it is. If that woman sent to you and you pop a speculum in and have a look and there's no discharge, there's absolutely no point in doing a vaginal swab. It won't give you any information. It'll end up giving you something like scanty growth of candida or occasional anaerobe in there. And then you don't know if they need treatment or what's causing it, what needs to be done. It just generates work. So I will get you to challenge. If there's no discharge there, you do not need to be doing swabs. And this test is a test for a discharge that you do not know what it is or it's not responded to treatment. So that's your charcoal swabs. The other time we would use these sort of swabs would be if you don't have access to the dual NAT testing, and anyone that uses the Durham lab And we don't have access in the community to get gonorrhea testing on our dual test, so we can only do one of these tests. And the problem with these tests for gonorrhea is most of the time the gonorrhea doesn't survive long enough in that transport medium for the lab to grow it. So it's not a particularly good test when we're testing for gonorrhea in the community. Which leads me on to NAT testing, because these are our gold standard tests for chlamydia and for gonorrhea. Now, the difference between this test and the one before is when you put the cotton wool bud and you again take a sample, and the sample of this discharge, you might want to take a sample of discharge and pop it inside the medium, snap the cotton bud and put the lid back on. This sample looks for pieces of DNA. And we're all expert on PCR tests now due to this pandemic, because we're all obviously immunologists as well as epidemiologists and experts in lab tests. And the NAT test, or the PCR test, looks for pieces of DNA. And it's DNA that's unique to that sort of bug that you're trying to grow. So if you tick the box for chlamydia, they'll be looking for chlamydial DNA. Now, DNA will be present even if the chlamydial cell is dead. Even if that's not alive anymore, you're still going to get pieces of DNA. So the nice thing about this test is you can do it on Friday afternoon, even if you've missed the courier. It can sit on the top, doesn't have to go in a fridge, and it can go off the next day or after the weekend to the lab, and the DNA will still be in there and you will still get a result. And you can do chlamydia tests with this, and you can do gonorrhea tests with this. And you can also do tests if you're querying herpes simplex. So for instance, if you're not sure if something's a cold sore on the lips or the genitals, you can use this test to do a herpes simplex test as well. So this is a NAT test or a PCR test. And a lot of people will have access to a dual test, and that would be chlamydia and gonorrhea on the same test. But like I said, if you're using the Durham labs, we can't access that on we can't access the gonorrhea test on the dual lab. We can only access the chlamydia test on there. And again, there may be different colours and different shaped bottles and different coloured swab tests. So it's important to be familiar with what you've got in your cupboard. And the other thing that you must do as well is check the expiry dates, because there's always a few hidden at the back of the cupboard that have been there since 2001 and they're well out of date. So always have a quick check of those, quick stock and rotate around so they're not going out of date. So they're your NAT tests. Now we've talked about chlamydia testing and gonorrhea testing. And then we've also talked about the usefulness of the swab for vaginal discharge. So all the guidelines we've got on testing have come out of the BASH, British Association of Sexual Health and HIV. I'm going to show you a link to that later on. Now, for women, we might be wanting to do chlamydia tests for instance, commonly in primary care might be for pre-coils. If we think a woman needs a pre-coil swab test, chlamydia would be the only test we would need to do, unless you felt they were at risk of gonorrhea as well. So we could do a chlamydia test. And if a woman's got no symptoms, the BASH guidelines say they can take their own swab. And it doesn't need to be from the endocervix. So you don't have to put the cotton wool bud inside the cervix. You can just put the cotton wool bud into the vagina. You put it in for about 10 seconds and you gently swish it around. And then they can do it themselves and put it into the pot. You do need some clear instructions to give them. Otherwise you get all sorts of combinations of things going wrong, including people trying to shove the cotton wool bud through the actual end of the pot. You get them chucking away the liquid. You get them using, there's 2 swabs in our ones, and for some reason the lab won't do it. If it's the white swab, it has to be the pink swab. So you'll get all sorts of varieties of things going wrong. So it is useful to have some instructions for them that they can take their own swab. If you've got access to the dual one, you could do chlamydia and gonorrhea on that. So far, that's only one test. Okay, so these would be women that will probably be coming for coils, but you might want to be doing some other tests. For instance, if a woman was presented with persistent irregular bleeding, you would be considering doing a chlamydia test, but because they've got symptoms, it's always an important thing to examine them. So therefore you do the test whilst you're examining them. So that would be self-taken swabs. You can do it for chlamydia and you can do it for gonorrhea. And then gonorrhea, just whilst we're talking about it, if you are suspicious of gonorrhea, so for instance, if someone contacts you and says they've been told by someone from the in contact by GUM that they've got a contact with gonorrhea and they don't want to go there, they want to come to you, do everything you can to send these people up to GUM. Okay, because when we're talking about gonorrhea, we're talking about multi-drug resistant treatment, and it's not the sort of thing that we're going to be prescribing in primary care. It's not the sort of thing that we would be doing, and it needs to be done correctly and accurately. So if there's anybody that's high risk of gonorrhea, be it their sexual behaviour, be it they've been a contact, or you just think that they've got a really mucky, horrible discharge and you don't know what is going on, these people should be going signposted up to GUM, because gonorrhea really needs treating appropriately. And if we give them inappropriate antibiotics, we're just feeding the multi-drug resistance that's being out there. So gonorrhea, straight away go to somewhere else. Send them to GU for that. Now, the other thing before I go on to this is, if you do want to do a gonorrhea test on a NAT test and you use the Durham lab, they will do it if you phone them up, and you really do have to argue why you need it doing on that test. So it's quite a lot of extra work. Now, the community cash clinics and the hospital services can do dual testing in Durham, so that's why you need to use them if you can't get access to it yourself. So let's talk about when you're going to do these tests, okay? How soon after exposure is it worthwhile doing chlamydia, gonorrhea, HIV, or pregnancy tests? So we've already done the pregnancy test, and you should all be well familiar with that answer. But just for 2 minutes, fill in this. What are your numbers? How soon after someone's had sexual contact is it worth then doing a chlamydia test or a gonorrhea test? Oh, I showed you the answers. No. Okay, so ultimately, if someone's on your telephone screen for something that happened last night, it's probably a bit soon to be testing for any of these things, but you can always do a baseline test if you wanted to. But you've got to remember the time it takes to get an infection and for that infection to grow and then for your test to become positive. And you already know your pregnancy test, you need that 3 week after you've had sex. There's no point coming the next day and doing a pregnancy test. Unless there's been loads and loads of episodes of unprotected sex. But for chlamydia and gonorrhea, you need to wait about 2 weeks before that test is accurate. Okay, and with HIV, the guidelines have changed, and you just need one test at 4 weeks, so one blood test at 4 weeks. But the guidelines say we should always do our baselines, but it's getting them back that's the important bit, to when to repeat them, getting that second follow-up assessment done. So that's when we're going to be doing the tests. But we need to be really familiar. If we're going to be doing these tests in primary care, we really need a good set of systems in place so things don't go wrong. And this was my sort of experience of when things have gone wrong before in primary care, is first of all, you will get complaints if somebody isn't told what you're testing them for. Now, you have to be clear and confident about why you're doing the test, and non-judgmental. This is nothing to do with how many people I think you've been having sex with or your sexual behaviour. This is about me needing to know whether you have an infection or not. Yeah, so let the person know, woman or man, whoever's doing the test, that this is a sexually transmitted infection, and I need to know if you've got this or not, because we need to know if you need to be treated. Yeah, if you've got funny irregular bleeding and you've been married for someone for 45 years, well, married a bit young then, haven't you? But say 30 years and you've never had another sexual partner, and you don't think your partner has, you probably haven't got an STI. But unless I test for it, I don't know the answer. So it's not about being judgmental, it's about being honest about, I need to just get this one ticked off my list of things to worry about. Let's just get it checked. Let the woman know that it's an STI test you're doing. Beware your false negatives and beware your false positives. Now, false positives are really not very common at all with chlamydia, gonorrhea. But your false negatives could be if you do the test too soon. The next thing is making sure that there's some sort of contact detail in the notes, like a mobile phone number, because the times you get a positive result back, then you can't get hold of someone. It's an utter nightmare. So if you're doing tests, make sure, just double check those contact numbers all the time. And then the other thing, remember to do, if you get a positive STI come back, it's not just that one person that needs sorting out, it's anybody they've had sex with in the last 6 to 12 months. And that then sits outside your role in primary care. And that's when you might need to get a health advisor and the GU team to help you with that bit of it. If it's really very straightforward and there's only one other person to contact, you could ask the patient if they contact them and get them to get treated or seen. But ultimately, if it's a complete mixture of lots of different people, that is not your role to do that. You need to refer them to GU who will pick that up. Okay, so it's making sure that you get everybody treated appropriately and tested as well. And during the treatment, they should all be told for the week of treatment, there should be no sex during that week so that we make sure they're not getting reinfected. So there's the main pitfalls when we're talking about STIs in primary care. Okay. If there's any questions, anyone can fire them into the chat function. That's great. I'll pick them up at the end. And you can fire them just to me, or you can invite them the whole group, it doesn't matter. Okay, so let's go on to the screening program. And I know I've got quite a lot of nurses in tonight that will be doing this and we're going to your updates. So this should be anything new. But these are the most recent stats that I could find on the Cancer Research UK website. And it really breaks my heart when you still see people that are dying of cervical cancer, because it's nearly 100% preventable. And still half of them are dying when it's such a shame. So although it's not a particularly common cancer, and our screening program is fantastic at picking precancerous changes up, and despite all of this palaver, you're still calling women in and nagging them to come and get their smear tests, and it's always worth it. It's such a shame when we still see women that have developed cervical cancer. So the biggest risk factor for developing cervical cancer is never coming for your smear test in the first place. So if anybody's got any bright ideas of how they've improved their uptake, I would share it with us. That would be fantastic, because that's just one thing that our youngsters aren't brilliant at coming. Our 25 to 30-year-olds often just don't come in for that first one. Once they get established, they're better. And again, our older ladies drop off and don't come because it's uncomfortable, it's dry, they don't want to come. And again, we need to keep encouraging those, because we've got two cohorts that get cervical cancer, our younger women, but also our older women as well. So it's encouraging them to take this free screening program and use it. And we all know about the HPV thing. It's been around for years now. And the good news is we're doing the boys as well. That was started last year, no, the year before last, 2019. And it is making a difference in the number of HPVs that are coming, of CIN changes that are coming through now. And the reason we're going to HPV screening is because it's better. It's better at picking up high-grade CIN changes. It's better than looking at the cells. And it's also better, and you have a lower false negative. So if you've got a better test at both ends, so it's great. And this is the slide again, sort of most recent stats looking at cervical cancer. And generally that trend's been going down. It's gone down quite well in the late 1990s, early 2000s, bit of a plateau. It spiked when we started doing the girls. Wonder why that was. That's what that spike in 2008-9 is, because they weren't the ones getting the cancers, but that's a strange little spike. And then it's continued it's about the same. It's going down a little tiny bit. But what we are noticing is the precancerous changes are going down. And that's what we'd expect, because 10 years on from screening, it takes about 10 years from HPV infection to it developing into cancer. So what we're doing is, by HPV immunizations, hopefully we're seeing that the less precancerous changes are developing, and then that will knock on to less cancers going forward. And if you've read that slide as I've been talking, you can see that the rates of CIN2 in young girls, 15 to 19-year-olds, well, we don't do that, do they? But the studies that looking at those, they've fallen by half, which is fantastic. And CIN2 with women that 20 to 24 have also gone down as well, so that's good. But our older women who haven't been vaccinated hasn't made an impact in those. So, it's making a difference. And those stats hopefully will show our cancer rates coming down going forward. And maybe one day, I was thinking it'd be great if they're sent in the post a pack where they do their own swab looking for HPV, and only the positives then come into us for the smear part of it. And it's a bit of a complicated slide, but just to remind you, if you're HPV negative, if you haven't got HPV, you can be almost 100%. You can never be 100% in this world, but almost 100% sure there is nothing abnormal, and you're put on your 3-year recall. If you're positive, they look at the cells. If there's any abnormality in the cells, you go to COLP for a checkup. If the cells all look normal, you get your repeat one done in 12 months. And that's just the top bit of that algorithm. It's just quite important to sort of be familiar with that early part of the algorithm, just so that you can reassure them when they're coming in. If you haven't got the virus, we really aren't worried about you. I thought we'd throw some nice pickies in just to keep you awake. Because you lot will be doing lots of smears, lots of looking at what is normal, what is abnormal, and I'm sure you all recognise this as an ectropium. It's a nice, lush, pink-looking ectropium. Sometimes they bleed a bit, sometimes they cause a bit of discharge, and when you take your samples from them, sometimes they do bleed a little bit. So you might be worried, thinking, oh, it could be CIN because it's bled, but sometimes it's just an ectropium. And I showed this picture before to the group before, and someone said that looked like a polyp, and I think it looks like a polyp, but it's just some sort of version of Nabothian follicle. But if you looked at that, you probably wouldn't like that so much. You probably think, I don't like that. Certainly smear takers, could you do your smear if you saw that? I can't see the transitional zone on there, so I don't think you could really do your smear very well. So that would maybe need referring to somebody to get sorted out. And if you thought that was a cancer, I don't think anyone would tell you off, because that doesn't look right. But the thing that's about that is it's smooth in outline and it's kind of regular in shape, and cancers aren't smooth and regular, they're chaotic. So that's some sort of Nabothian follicle. And this one again here, this is some sort of ectropium, but you can see the arrows people have put on it. Obviously the colposcopist that's taken this picture has got some concerns about the vessels and some concerns about the white patches. And if you had a look at that and thought, I don't like the look of that, no one would tell you off for saying that needs to be referred to somebody else under the abnormal looking cervix category. Perfectly okay. All right, if you need to do a smear, it's a screening program. That's all we're doing. Okay, we're screening the NHS patients. We're not testing the NHS patients with this. And if you think that looks a bit abnormal and not right, someone needs to look at that with a colposcope, and that's perfectly okay. And this is more typical in Nabothian follicles that you'll see all the time. Those little, they look a little bit acneified, like little, and if you pop a finger on them, they're lumpy. They're like little nodules. And again, they're really common and they're benign things. They're nothing to worry about as such. And you can see this lady's got multiple Nabothian follicles on her sample. But if you have a look and see that when you're passing your speculum, well, that just looks like a mess, doesn't it? You've got irregular bleeding sites, you've got discharge, you've lost your anatomy, there's no regularity to that, and that looks horrible. And I'm sure most of you that would have a look at that would think, ugh, that just does not look right. You wouldn't do a smear test and wait for the result. That would just go straight up to secondary care under the abnormal looking cervix 2-week pathway. What is that? That's got to be a cancer. That just does not look healthy. And that's a really horrible cancer. So, you know, that's been there a while. And you can see what that lady's going to present with when she comes through the door. It's going to be some sort of irregular bleeding pattern, because you can see how bloody and horrible it looks. It's bleeding, and there's also discharge around there. So blood and discharge, you know, can be that. So the first thing you would do if your woman walked in there would be look at her cytology history, because you bet your bottom dollar she's never come for a smear test. So if anyone's got any tips for me that I can share with the group about how to get our women in for smears, especially at the moment, I'd love you to share them with me. That'd be great. Remember, we're doing a screening program. So we are offering in primary care HPV screening with cytology screening. We're not doing anything different than we've done all the way through. Yes, the brush might be slightly different and we have to mush it, but the whole process of actually physically doing the test is exactly the same for us in primary care. But we are simply doing a screening program, screening women when they're due to being sent an invite to come in and get their smears done. This is not a diagnostic test for us, and we shouldn't be doing it outside the screening program. And in fact, they'll just be rejected now. This is simply as part of the screening program. So let's do a case. So Emily, 23, and she's got a discharge. So this is what some really simple guidelines were that I took from the Primary Care Women's Health Forum. This is what they say. So she's got a vaginal discharge. Obviously, you need more information than that, but you would test her for chlamydia and gonorrhea using a vulvovaginal swab. Okay, she could do her own if you wanted to. That's all right. She's got symptoms, but she could still do her own. And if you've got the dual test, brilliant. If you haven't, I would just do chlamydia. I wouldn't do the gonorrhea. If she needs a smear, she can have a smear, but she doesn't. She's too young. She wouldn't have been invited yet. Then, if she complains of itch with a discharge, treat her as thrush, treat her as candida. If she complains of offensive odour with a discharge, treat her as BV. And if she's got complaints of both, treat her for both. Now, if it comes back or if it doesn't improve, then bring her in and examine her and test if you need to. Okay, so this is perfect for telephone stuff, yeah. Have a chat. Now, she's going to be offered a chlamydia gonorrhea test because she's under 25 and she should be getting them done anyway. It was good practice, especially if she's got a new partner, any risk factors, and her age on its own is a risk factor. So invite her for a chlamydia gonorrhea test, fabulous. But ask the questions. If it's itchy, give her thrush treatment. If it's smelly, give her BV treatment. If it's a bit of both, give her a bit of both. And then if that doesn't work, bring her back. So that's easy, that's simple. What about Edna, who's 72, and she's got a bit of thrush as well, and she's on the phone to you. So should we do the same thing for Edna? Should we get her in and test for chlamydia and gonorrhea? I mean, who knows what Edna's been up to? There's some pretty good parties going on, I hear, at the moment, especially if you're in concert at the moment. That rave they broke up at the weekend. I don't think Edna probably will be going to that rave, but you shouldn't be ageist or make any assumptions at all in our jobs. She doesn't need a smear because she's too old now, isn't she? She's out the end of the smear programme, unless, of course, she's had some sort of abnormality. And so if she itches, should we give her a bit of thrush treatment, and should we give her a bit of BV treatment, or should we bring her in, or what should we do? But let's look what NICE say. NICE say, vaginal discharge, either at first presentation or with thrombocytosis or hematuria in women over 55, we should be considering endometrial cancer. So this is a completely different pathway for an older woman. And remember, an older woman who now is postmenopausal will lack estrogen, and she will not have a vaginal discharge. Her vaginal mucosa will be thinner, not producing any discharge. And so actually, if this woman suddenly presents with a discharge, your ears should prick up and you should be thinking about more sinister diagnosis, for instance, endometrial cancers. And we had a chat this morning about just exactly a very, very similar case someone had picked up. So think about endometrial cancers. They don't only present as postmenopausal bleeding. Sometimes they're older women with discharge. Sometimes it could be slightly pinky or mucky sort of discharge. So that's when you should be considering endometrial cancer with that. So you get your chlamydia result back, and here you go, here you've got your positive result back in here. So what are we going to do? What are our treatment options? Well, it's okay, don't worry if you don't know, because I'm going to show you where all the guidelines are you can go to in a minute. But the treatment options for her would be, first line would be doxycycline for a week, 100 twice a day for 7 days for a woman, or you could give her azithromycin as a 1 gram dose. Each have their pros and cons. Azithromycin, 1 dose is dead easy to remember and take, whereas a week twice a day is less easy to remember to take. But doxycycline also penetrates other extragenital sites. For instance, if you've had anal sex, you've got chlamydia around your anus, it works better. If you have it in your mouth because you have oral sex, then that could also, that's treated better with doxycycline. So how long should you remain abstinent afterwards? Rules are still 7 days, okay? And do we need to do a test of cure for these people? Well, no, only if you're pregnant. So we don't routinely offer test of cure, and that's because the antibiotic treatment is so effective at treating it. If you are persuaded to do a test of cure, you must leave it for at least 6 weeks, because it takes about that amount of time for your body to get rid of any dead chlamydia that's still in it. And if you have dead chlamydia that's been treated with antibiotics and you swab it, you'll still have DNA on your swab, you'll still have a positive test, so you'll get a false positive. So leave it for 6 weeks before you check. And that's quite handy for coil fitters out there. You know, if you get a positive chlamydia, treat them, but I would delay it for 6 weeks, and I would quite like to know that it's been cleared up and gone before I pop the coil in. And then partners, don't forget the partners. All the partners need to be offered a full STI screen, and that's best done through the GU services if you can get hold of them. So that's chlamydia in primary care. Know what you can do safely, know when to refer on. But if you ever get this, remember secondary care. If you've got the dual testing and you get a positive gonorrhea, please always refer them to secondary care and do your best to persuade them to go there. You can't offer a good service in primary care for these people. So that's gonorrhea. So we'll just quickly go back to this good old slide. And really, I'm just highlighting the second bit down, or the third bit down with the blue and green lines, your LH and your FSH, your hormones that surge just pre-ovulation to cause that ovulation, the maturity of the follicle, and then the ovulation. Those two hormones that are generally lowish, but have a little surge mid-cycle just to create ovulation. And remember, your estrogen and progesterone levels are kind of going up and down in a range, which is vast. The range is huge for the hormones. So in a woman who is menstruating regularly with a cycle, you'll see some changes. And what you have to remember is when we're doing blood tests, we're only taking blood tests on 1 day, 1 minute, 1 second of that cycle. So they only apply to that little bit of the cycle, yeah? So I thought we'd have a look at FSH and LH, because that's one that we get asked to do all the time, isn't it? I need an FSH, I need my hormones checking, am I menopausal? And this graph shows you that ovarian reserve, or the number of follicles within your ovaries, is you're born with a finite number, and over time those number of follicles decrease down slowly till you hit about the age of 50 where there's virtually no follicles left. And when there's no follicles left, your FSH can shout at your follicles to release an egg, but there's none left. So they have to shout louder and louder and louder, and up goes your FSH and it stays high. And your LH does as well, but FSH is the one that we really test. And the contra to that is with no eggs left, your estradiol levels start to dip and stay low, and so do your progesterone levels. So for menopausal women, we'll see a persistently high FSH and a low estrogen and progesterone. Makes sense? Dead easy. But we've got to remember, this is what NICE say to us. Menopause is a clinical diagnosis. It means 12 months since the cessation of last menstrual cycles. You can diagnose it on history. And the average age for your periods to stop is 51 in the UK, but the range that is normal is 45 to 55. And your symptoms can start 5 or more years before your periods stop. So there's little point in doing FSHs in women who still have some sort of bleeding pattern, because they have no value. If we go back to that slide I showed you at the beginning, generally they're low, but you might catch the peak anyway mid-cycle. And if there's still some sort of bleeding going on, then there's little value in checking FSH. Now there's a caveat. You've got 30 seconds. Can anyone think of any caveats and jot them down? Which people might it be useful doing an FSH in? So I'm hoping you've got a few between you. Right, so I'm hoping that some of you might have thought about, are women using Mirena? When can we take the Mirena out? Or in fact, when can we stop a woman's contraception? Those women that are using hormonal contraception can be really difficult to know when to stop using it, when they're using POPs or they're using Mirenas. And so you might want to check FSHs on those women. But it's not a lot of use in depot, and it's not a lot of use in combined pills. So combined pills, you can't check it at all. So really at the age of 50, you're probably considering taking them off that anyway to an alternative. And depot, well, our women should probably be off it anyway when they're hitting 50. So again, getting them off to maybe a POP, persuading they could have a Mirena maybe, they'd be ideal for that. So there is some roles for FSHs, when to stop contraception. Now, I tell my ladies, look, when you're 51, there's a 50-50 chance your periods have stopped. So let's not even bother until we've got to the age of 51 or older, because then we've got a chance. There's a 50, you know, the odds are with us then beyond there. So don't start doing it much younger than that, unless, for instance, you felt someone was getting lots of symptoms, lots of menopause-like symptoms, you've been having them for a while, and you think, well, this woman might be menopausal. I tend to leave it till they're 50, 51, and then say, look, we could just leave you on some sort of contraception till you're 55, or we could do these tests to see if you still really need it or not. You can also check it with implant users as well, that's fine. It's just your depots and your POPs. It's depots you can, but you should really have them off depot at 50. When else is it useful? Well, it also isn't any use if a woman's already started HRT to tell her when to stop her contraception, because the HRT will disguise her menopause bloods as well. So those women, you can't really do it with either. So there are a group of women on hormonal contraception that it is useful for checking FSHs. So roles of FSH then. So here we go. Here's another case. Let's look at the other spectrum. We've got an 18-year-old girl whose BMI is 17 and she stopped her depot 6 months ago, and they said her periods haven't come back. So piece of paper in front of you, anybody that's got access to tests, what tests might you want to do for her? Right, so hopefully you've jotted a few down. So we're looking at a young woman with secondary amenorrhea here after depot. So you might consider these tests for secondary amenorrhea. You might consider looking at her LH and FSH to see whether she's been very unlucky and gone through a very early menopause, and her estrogen conversely will be low if her FSH and LH have gone high. She'd be really unlucky at that age to have done that though. You will be checking a prolactin to make sure she hasn't got a prolactinoma, which can completely stuff up your cycle, which would be very rare. More common in people that are taking the new antipsychotics. They're not that new anymore, but olanzapine, risperidone, they can cause high prolactin levels. But a prolactinoma might be a rare complication causing secondary amenorrhea, and so can extreme thyroid disease, but usually it wouldn't be the only symptom. And you also obviously will be considered pregnancy, because obviously she might have got pregnant in the interim, her period hasn't come back yet because she's got pregnant before it's come back. So those are things you might be considering in there. And we'll talk about the limits of doing those tests. Because I'll tell you now, when you do these blood tests, a LH-FSH will be normal. It'll be about 7 or 8, so it'll be a normal, it won't be raised. And her estrogen levels will be okay. There'll be a couple 200-300, which is fine. It's a normal range for a young woman. And her prolactin will be fine. It's not going to be particularly raised. And her thyroid is going to be fine, and she'll pregnancy test negative. But you've got the answer. There's 2 reasons her periods haven't restarted. One is her BMI. She is probably on the threshold where she is underweight. And obviously when there is a threshold with women, when their periods stop because of their weight. And the second thing is she's had depot, and depot can sometimes cause anovulation for a long period of time after, and you simply have to sit and wait. But if you do the hormones and they're all normal, encouraging to put half a stone on often will make a cycle come back, but obviously encouraging to continue using contraception is really important. So there's 2 things there, the secondary amenorrhea that we see all the time, depot and being slightly underweight. Why did I put that slide back in? Angela, let's have a look at Angela. So this is a different lady with heavy menstrual bleeding, okay? She's 47. Her periods are gradually but slowly been getting heavier, but she doesn't have bleeding in between her periods. She doesn't have pains or bladder problems, and she hasn't got any pressure symptoms or weight in her tummy or bloating or anything like that, but she does feel tired, okay? So you've only got access to 1 test. What is that 1 test you want to do? Jot it down on a piece of paper. 1 test only. Right, so I'm hoping you all said this. All you're going to do for her is a full blood count. Okay, that's all you need to do. That's all NICE want us to do. They don't want us to do hormone profiles, thyroid tests, ferritin, anything else like that, or an ultrasound scan in this woman. All she needs is a full blood count. And what you're doing is using your full blood count as almost like a line in the sand. If someone has a normal full blood count, their chances of having any significant pathology are significantly reduced. Okay. If her full blood count shown that she's developed anemia, you're probably going to find signs of microcytic anemia, so iron deficiency anemia. You may then want to follow up with a ferritin level, but you don't have to do it on everybody walking through the door. You would choose to do it if they were ghostly pale and had every symptom going of anemia. But a full blood count is all you need to do, and you certainly don't need an ultrasound scan in this lady either. If you've got anemia, you're much more likely to have significant pathology. And those two common pathologies are going to be fibroids or polyps, which cause you to have heavy, clotty and flooding periods. And a great question to differentiate the woman that's got heavy periods, remember this is all subjective, you're not measuring it, is do you have to get up at night time to change the sheets, or some women sleep on a towel, they're so heavy. So if you're getting up at night time to change, that can be a sign things really are heavy. So full blood count, heavy menstrual bleeding, whether they're regular cycles or some irregular cycles, full blood count is all you need to check. Don't go doing hormones, there's no value in it at all. Remember I told you FSH, no value in a woman who's still having her periods. Okay. So I thought we'll talk about CA125. So it's our tumour marker looking for ovarian cancers. So we should be thinking about ovarian cancer in women that present with any sort of bowel-like symptom. So that can be bloating, abdominal pains, pelvic pains, change in bowel habit, weight loss, and you can start adding other things in. NICE asks us to consider it in women with fatigue. They ask us to consider it with bladder symptoms, frequency and urgency. And so there's a whole selection of people, particularly a woman presenting who's age 50 or over with bowel-like symptoms, we should consider a CA125. And a CA125 is, they ask us to do one on the 2-week bowel form for women, and that's because the bowel symptoms can overlap. And if a CA125 is above 35, there should be a trigger for you to do an urgent ultrasound scan. Now, ovarian cancer isn't our only reason why CA125s go up. Any sort of pelvic pathology can cause it, particularly fibroids, infections, pregnancy, endometriosis. It can also go up in bowel cancers. So there are lots of reasons it can be raised. And also the other side to that is you can have a woman with ovarian cancer who has a perfectly normal CA125. So it's not a brilliant test, but it's the only test we've got in primary care, and it's the only test we should be doing. We don't need to do any other tumour markers. Okay. And I thought whilst we're on it, I thought we should talk about HIV testing. And I don't know if anybody's watched this, it's a Sin that's on Channel 4 at the moment. It's brilliant. It's a series looking at the HIV epidemic in the late 80s. And it follows these housemates who've gone off to uni in their adventures, but unfortunately their adventures around then also everyone catching HIV and all the consequences. It's just awful to think what people went through and still go through. There's an element of it now. So HIV testing in primary care. When these guys in this programme went for an HIV test, they would have had 45 minutes of counselling before they had their test. When the character Ricky at the front with the blue coat and went to get a mortgage, the mortgage person asked him, had he had an HIV test? Okay, no wonder people didn't want to go and get tests. They couldn't get mortgages, they couldn't get insurance, there was all sorts of problems. Nowadays, we're trying to normalise that test. If you have somebody who has symptoms of an immune deficiency, they're getting lots of infections, they've got recurrent thrush, they've got lots of chest infections, they're tired all the time, they've lost weight, they've got lymph nodes up. we should be checking HIV tests in primary care, and the only counselling they need is to be told, I'm checking an HIV test on you. They don't need anything else. If you work in central London, everybody that's new to your practice gets an HIV screening test as a new patient checkup. If you're pregnant, you get an HIV test as part of your booking bloods. We should not be putting stigma and accepting people need counselling before we do HIV tests as part of our tests in primary care. So we should be challenging, if anybody's got any symptoms that you're concerned about, that you think possibly could be HIV, do the test, check it. And unfortunately on ICE, it still says, if you tick the box, it still says, has this patient been counselled? And we should be getting rid of this rubbish. We should just be any other blood test. Remember, HIV, the sooner we pick it up, the better the diagnosis is, and much better picking it up as HIV than before it's turned into AIDS, you know, when people have got conditions that are immune deficient conditions. Okay, so you are better off doing these tests and picking it up earlier. The people that get picked up early can live a long life and they die of something else. It's not the HIV AIDS that caused them to die. They die of other long-term conditions at a decent age, and it is not the death sentence it used to be. But if we don't do the tests, then we're failing to pick up these people. So see it as a normal test we can do in primary care, and challenge. People still say now, oh, they need to go to the GU clinic for that test. No, they don't. Anybody that's been pregnant out there, when did they bring this in? They bring this in about 20 years ago. It's just part of pregnancy screening now. The midwife doesn't spend 45 minutes counselling you. She just does it. In fact, you probably don't even know you've had it checked. So make sure that we don't stop people having access to these tests. And so if you're going to do these tests as well, same rules apply. Make sure you've got a phone number you can contact people if you need to. Okay, so HIV testing, do them, and there's a role for them, and do them. Okay, so whilst we're on tests, shall we talk about scanning? We do far too many ultrasound scans in primary care, and we regularly get the emails of shame from the radiographers denying us that for whatever reason they've denied us this, it isn't needed. But we do a lot too many. So question, do we really need to do it? For routine heavy menstrual bleeding, there is no need to do an ultrasound scan. We might need to do it if it's anything other than heavy menstrual bleeding. So if there's any signs of a mass, a lump pressing on your bladder, maybe erratic bleeding, although not everybody with intermenstrual postcoital bleeding needs it. It doesn't really need it for HMB. It doesn't really need it for most intermenstrual and postcoital bleeds, but we often do it, and you can do it, but it often doesn't show us anything of any use really. And often what they need to be doing is they need to be sent to Dr. Sen's clinic for the menstrual disorder clinic, because they need a hysteroscope. They need the inside of their uterus checking out. They've got polyps, they can see them. You can't see a polyp on an ultrasound scan. You might have a slight thickened endometrium, but you need a hysteroscope to find out what's going on for these women. So it doesn't add an awful lot of information to them. For amenorrhea, it's no use either really, it doesn't add an awful lot. So our patient before, we could scan her, but it's not going to show us an awful lot. And most pelvic pains, it doesn't show a lot, unless you think this could be a cyst, is a unilateral pelvic pain gradually getting worse, and you can feel something, maybe those women ought to get it. So pelvic mass, some sort of lump, then yes, they're the sort of people that it's much more useful for doing. But you could argue we do a lot of these tests to reassure patients and to stop them having to go up to secondary care for other things. And that's a valid argument too, I think, but we do too many probably. And then I thought I'd just quickly talk to you about endometrial thicknesses and cysts and follicles, and when's a cyst and when's a follicle big. And I like that picture because I remember once having a lady that I got a discharge letter off from secondary care to say that they'd removed a football-sized cyst on her ovary, and I hadn't picked it up. And I remember phoning Fiona Lloyd with the consultant, and I was mortified. I can't believe I missed that. I got your discharge letter. She said, don't worry, we missed it too. But she went through the CT scan and we found it. So remember, there is a limitation sometimes, and BMI is certainly one of the things that makes it harder to pick these things up. But first question, when is an endometrium too thick? Well, there is no guidance out there. Okay, I've seen it on reports, 1.5 centimetres or 15 millimetres needs urgent referral. There is no guidance on how thick an endometrium should be in a woman who is menstruating. In a postmenopausal woman, they use cut-off, depending on which guideline they use, of 3 to 5 millimetres. So a postmenopausal woman should have virtually no endometrium, but a premenopausal woman, there really isn't clear guidance on the thickness of the endometrium. When is a cyst a cyst and when is it a follicle? Now, every month you get an egg that is grows, and it grows in a little container of fluid. And fluid is very easy to see on scan. They show brilliantly. And as that bag of fluid gets bigger and bigger and bigger, it's easier and easier to see it on a scan. And eventually, when you get a little LH and FSH surge, that bag of fluid will burst and the egg gets released. So until it's burst, when you scan a woman, you will see a little bag of fluid in her ovary. Sometimes you get it in both ovaries as lots of follicles are growing, and then one becomes a dominant follicle and then it grows. So if you scan somebody at the time just before you're ovulated, you will see a clear fluid-filled cyst in her ovary measuring up to 3 centimetres. And in fact, the guidelines that the Royal College of Obstetricians use is a simple cyst, or a simple, which means it's got no walls in the middle of it. It's a clear bag of fluid. If it's less than 5 centimetres, they treat it as just being a follicle and leave it alone. So a clear, simple cyst, if it's less than 5 centimetres, is probably just a follicle and doesn't need anything doing to it. And finally, fibroids. Okay, fibroids are common. And NICE tell us that a fibroid that's less than 3 centimetres, we can manage it in primary care. And if we're fitting into uterine systems for the treatment of heavy menstrual bleeding or fibroids, then you can fit it in a woman whose fibroids are less than 3 centimetres. So a small fibroid less than 3 centimetres is one of ours. If you're getting to be bigger than 3 centimetres, you're probably going to be considering referring it to Gynae for some sort of other treatment. So that is when is a cyst a cyst, when is an endometrium thick, and when is a fibroid big enough to need referring. So that is that. Now, treatments. I'm not going to go through how you treat BV, how you treat thrush, how you treat recurrent, because if you go on the BASH guidelines, bash.org, bashh.org, you can go onto this page, which is their guidelines page. And if you click on it under current guidelines, you will find everything you ever need to know about how to treat thrush. What's first line, what's second line? What if they're allergic to this? What if it's come back? What if they're recurrent? There's BV in there. And all the different treatment options are in those BASH guidelines. So it will tell you what to give for herpes and what to give for chlamydia and gonorrhea, although you're not going to be doing it. So it's all in there. So you don't need to worry about memorising how to treat it. The common things are on our GP team net in the prescribing formularies. And the things you might want to look up are within the BASH guidelines. And it's just useful to know that so you can take your time over looking over it and what to do with it. So that is a link to the BASH guidelines for treatment options. Before we go on to questions, I thought I'd just talk to you a little bit about some of the other treatments that we give. And particularly I thought I'd talk to you about Provera and norethisterone, because norethisterone is a flavour of the month in our summer months when people used to go on holiday, and we used to dish it out like Smarties because it's a high dose progesterone, and we would give it to women to try and prevent them having a period when they're on their 2-week break in Turkey or wherever they were going. Then I think it's about 2012, Diana Mansur wrote a really great paper, and it showed us that the reason it works so well giving norethisterone, so you might give 5 milligrams 3 times a day, so 50 milligrams a day, is the body converts some of that into an estrogen. And if you give women estrogen and progesterone, guess what we're giving them? It's a pill. And that's why it's so great at stopping you bleed. It's really effective. We weren't doing any pill assessments, and really by that I mean VTE assessments on these women. They were getting a couple of packets of Provera and northisterone and going off on their jollies, and we were basically shoving them on the pill, which is all very well unless your BMI is high, you're a smoker, you're on a long haul flight, and your risk of a DVT is probably quite high. So after that came out, the guidelines suggested that we use Provera. And the reason is because there wasn't any evidence that Provera actually did cause problems around VTEs like northisterone could do. So Provera became a more popular product because you didn't need to do the thrombosis risk assessment that you do have to do with northisterone. But who knows going forward if someone's going to look at that in more detail. So at the moment, Provera, 10 milligrams twice a day would be my treatment of choice if we wanted to try and stop sort of a heavy bleed or something like that. Any other treatments I can think of that are new? The only other treatment that's new, that if you weren't at the talk I did the last week, is about Levocert, the coil that's come on the market, which is like Mirena, has the same dose as Mirena, now has a license to use for contraception for 6 years. So if you're a Levocert fitter, you can use Levocert for 6 years. It can stay in for that extra year, which is fabulous. You know, anything that can last a bit longer is great. So Levocert for 6 years for contraception. It's only got the 5 years for heavy menstrual bleeding, but if I would be saying if it's working, I'm going to get a 6th year out of that too, or longer if possible. So next question is, has anybody got any questions? And if you have, just pop them in. I can see there's a few already in the chat box. Bung them in the chat box, and I'm just going to bring a different slide up for you so you can actually then fill some feedback in and get your certificates from tonight. And whilst you fill in any questions, the next course is on the 3rd of March. We're going to do Women's Health, What's New. So I think I might do a little bit on NICE guidelines and clinical cases, and following those, see what we can be doing safely in primary care. And obviously, if you want to get hold of me, that's my email address, and the website also has a contact through the generic address, and that will come through to me as well. So if you want to ask me anything, feel free to send me some information, that's fine. So I'm going to just stop sharing you that, guys. 22 of you on. Oh, that's great. So 21. Get that for my... Now, hang on a minute. Okay. Oh. Right, there's the chat. Oh, you're quite a lot tonight. So paste there. So that is the link I've just put in the chat where you can go in, fill in the boxes, do my feedback for me, and then you'll get your certificate from tonight's meeting. So that's for you. You can just come paste that or do that now. So let's have a look. So can we override the consent for HIV on ICE? Right, good question. Just tick the box saying yes, you've done it. The consent is I'm doing an HIV test. That's all you need to do. Yeah, that's all you need to do. I would love them to get rid of it. I don't know why they can't get rid of it because it's not up to date, but I would just say, click it, say counselled yes. And the counselling is they don't need counselling. Tell them that you're doing it because they need to know what you're doing, you know. So, and someone said this to me once, which I thought was fascinating. You're quite happy to do an HbA1c on someone, aren't you, or a random blood sugar? If you're going to diagnose someone with diabetes, you're basically telling them they're probably going to die 10 years younger than most of the people around them because they are coming across a condition that has serious consequences and is almost definitely going to shorten their lives a bit. But you don't blink twice about doing an HbA1c. So we just need to normalise this, yeah? Get it done, get the test done. Right, here's another question. So primary care still refuse to carry out GP requests citing counselling and using HIV checks. Absolutely. And we've just got to break these barriers down. I mean, the pregnant women is such an interesting thing, isn't it? Pregnant women don't get counselling. They're just told they're having an HIV test. That's not, you know, so why should anybody else be doing anything different? Let's just keep challenging it and keep doing it. Right, next question. If putting a copper coil in for emergency contraception under 25, would you do a chlamydia swab on insertion, then wait for the results, or would you give treatment without a diagnosis? Right, what I would do is I would bring them in for the emergency contraception. I would put the speculum in and I would do a swab there and then. If it looked like there was any sort of discharge, I would put the coil in and give them chlamydia treatment. If it didn't look like there was any discharge, and I know that most chlamydia is asymptomatic, so you're probably not going to say anything, you will get the result back in 24, 48 hours. And if it's positive, then I would give the treatment. Okay. So that's what I would do. And you could argue that if you felt there really was a real, you know, you really felt this woman, and I've only seen this once where I thought, gosh, there's definitely some sort of really horrible infection going on there. Is it wise to be putting a coil in? You could put the coil in and get her through, you know, whether you need to use it for a week or two and then take it out potentially, as well as treating her. I don't want you to lose it. If you were really, really worried. But remember, you can still, if someone's got chlamydia, you can still fit a coil. You just need to treat them. It's only if they had active PID that you'd be thinking that needs to come out. So basically, I would definitely be swabbing at the same time, fitting it, and I'd give them some treatment if I was worried as well. If you thought you'd never get hold of them, they wouldn't come back, just give them the treatment anyway. How long can Provera be used for? Well, Provera is a high dose of progestogen. And basically, you're going to get progesterone side effects. So progesterone side effects are the hormonal side effects you get the week before your period. So bloating, spots, greasy hair, mood swings, feeling ratty, that sort of thing. So who wants to be feeling like that and taking Provera long term? It's all right. It's an interim drug. It's a filler drug. It's not particularly nice. How long can you use it for? As long as a woman can tolerate it. But generally, most women are only on it as an interim treatment, just for a short period of time, whilst they're going for some sort of other treatment. And it's all right for some women, but I haven't come across many women that said that Provera is cracking, doc. You've really sorted my periods out. I don't need anything else. Usually they're using it. They come back and they say, oh, it's not brilliant. So, and then I say, well, how about an IUS now, eh? Should we get it sorted? And usually they've come round at that stage. But there isn't a duration that you can or can't use it for. And typically I would use Provera 10 milligrams twice a day for 3 weeks on, a week off. It would give you a cyclical withdrawal bleed, which should be lighter. It will give you a regular cyclical withdrawal bleed, but whether you can tolerate the side effects when you're on it is another matter. Anybody got any other questions? Put it in the chat if you do. If not, fill in your feedback forms. And I'll start getting emails pinged to me tonight, so I can do that to get my feedback for next time. And any questions are here for another 5 minutes. Ping them through to me. I'm more than happy to answer them. Otherwise, thank you so much, everybody, for coming tonight. Hopefully you've got one thing that you can change your practice, that you can do differently. If you thought I missed something out, or if you thought I really wanted to ask that, chuck it in the questions now. Or if you think I missed something out that's really important that keeps coming, chuck it in the feedback so I can put it in the next one, so we do it next time. But thank you for listening, and look after yourselves, everybody, and hopefully see you at the next one. Okay, take care.
Thanks, Julie.
You're welcome. There's the feedback form again. It sort of disappeared up the screen. That's in the chat bit. So click on the chat bit and you can see that Durham Gynae link there. That should take you to the feedback form. Oh, it's definitely working all right. I'm getting emails pinging through now. If you haven't seen that, It's a Sin, go and start watching it. It's brilliant. Channel 4.